I think it's very important to find out where does all this begin. And so that's why I chose that you probably need to understand some basic things. What are these early origins of respiratory diseases? So I'm going to briefly talk about basic things about the respiratory system. We shall go through the burden of most common respiratory diseases we're familiar with, really. I'll discuss some of the risk factors for respiratory diseases, some of the interventions that have been tried. We shall gauge whether they have been effective or something needs to be done differently. And then I'll conclude. So this is familiar to us. We all have this system. Many times when we are talking about diseases, we think about the lungs, but as you will discover that the diseases that affect the lungs, it starts with what you breathe in. So it starts with a nasal cavity, down the upper airway, until the air finds its way into the lungs. So most of the diseases probably have their origins around things that are happening around the air we breathe. So that is the basic thing, and I want us to keep this in mind as we discuss the origins of respiratory diseases, but even later as we discuss asthma in detail, this basic structure of the respiratory system will become very important in understanding what we are discussing. And so I mentioned that we are discussing the origins of the respiratory disease, and we want to look back at the point when all this begins. And so that's why I put this slide showing that by the 3rd week after conception, the lungs have started forming. If you could kindly mute somebody. I don't know, I think somebody's mic was open. So I was saying that 3 weeks after conception, that's when the lungs start forming. And this process goes on of lung growth and development and maturation until somebody's about 8 years. Many times we think about lung problems or the functioning of the lung when the child is born. Sometimes they breathe well, sometimes they have problems around breathing, but some of the things we see at birth and beyond birth up to about 8 years and sometimes beyond are because of what happened during pregnancy. And as we shall discuss the interventions, you realize the role we have to play, especially our midwives, in trying to ensure that by the time the child is developing, even when they are still in the womb, they have a proper process or a normal process of having their lungs develop and grow, such that by the time they are born, they have normal lung function. And so all these stages that have been outlined, I will not go into the details, but the point I want to mention is that whatever insult happens at any of these stages can cause problems around the lung function. And if you have poor lung function by the time you are born, it actually increases your risk of getting both communicable and non-communicable respiratory diseases. And so what science has shown us that for a lung to grow normally, it goes through a series of well-orchestrated events. And you might be surprised that by the time you're 22 years, that's when you're able to realize the full lung maturation. So for all those years until you're 22, if any insult happens, you're more likely to have lung health problems or respiratory problems. And similar to what happens in general growth, for us in pediatrics, if you are very well aware about the child health card, we monitor the weight gain. And so the good thing about child health, when we are looking at the weight, if you're born below the normal percentile, so to speak, if they do the right things, you're able to catch up and cross from the 25th, the 50th, and sometimes you reach the 70th percentile. And so there is a catch-up growth that happens. Unfortunately, for lung function, research has shown that for most people, once they start in the abnormal part of the lung function, they follow the same process until they pass on to the next world. So we're very keen on making sure that we prevent this incidents happening, because the opportunity to catch up is not very common. And we know that when you have poor lung function, by the time you are born, again, like I mentioned earlier, the risk of having respiratory diseases increases. I'll just demonstrate this one a little more. You don't have to worry about the curves, but just look at the colors. So this graph was done by some researchers. They looked at what happens to the different people at the time they are born, specifically looking at their lung function trajectories. So if you look at the red line, there are some people who are born and their lung function is supernormal. So the lung function is normal, they raise through the childhood. By the time they are 20, they've reached the optimal. And then normally for everyone, once you hit the 22 mark, your lung function starts declining. It doesn't mean that it's not functioning well, or it's not normal, but the decline begins. So if anyone is on this call or on this Zoom and you're above 22, just know that your lung function has started declining. So if you look at that red curve, they have supernormal lung function. It declines, but not very rapidly compared to other people. Now the green one is where the majority of the people lie. That is the normal one. So again, it starts off nicely. Like I mentioned, that lung maturation continues at around until about 22 years of age. And then your lung function starts declining. So if you look at that green curve, for some people, they follow the green curve until 80 and so forth. But for others, they fall off that curve. That's what you see, the blue line going down very rapidly. And we know that some things happen along the path of their growth that makes them have accelerated lung function. And so as we look around respiratory health, we need to be sure that we prevent some of those insults that would make you start getting acceleration in your lung function decline. Now, the most unfortunate group is the lower curve, where they start at the abnormal lower centile, so to speak, and they reach abnormal, they don't reach the maximum lung function that is expected, but also their lung function decline happens much earlier, and so they end up having premature death. There is a small gray line which tends to show that you probably can catch up if you are born at the lower centile to the green line, but it doesn't happen for so many people. So what I wanted to show here is that if you're born with abnormal lung function, you don't have an opportunity to catch up, and your acceleration in the lung function decline happens much earlier, and therefore you die from lung diseases much earlier. And therefore this emphasizes the importance of preventing those insults that could actually make you be born with suboptimal lung function. So this is more illustration of what happens to the period of the prenatal. The curves I described earlier were just starting at birth, looking at lung function at birth. So they try to project what could be happening during the time or the antenatal period. So that would be the normal curve. The dotted line is when somebody's in utero, and then at birth, then the lung function goes up. At around 22 years, you reach your maximum, and then you start declining, and you may not get respiratory symptoms until you die off. But for some people, sorry. But if you have prenatal exposures, which we shall describe later, but any insult that happens to your mother when you're in the womb, it can affect you to an extent that by the time you are born, you have much lower lung function or subabnormal lung function, or sometimes we say it's not optimal. But even when the lungs start maturing, you never reach where you expected to be. And consequently, you get accelerated lung function decline, so you start developing symptoms early on. So many times we receive patients in our clinics and we think, where is this all coming from? We ask about exposure to tobacco smoke, we ask about the environment, we ask about infections and other things. And we probably only look back to a few years, but many times what we see in older children, in adults, most of these events may have been set off by what happened during the prenatal period. And therefore, if we are again looking at effective prevention of lung diseases, we need to look very critically at the prenatal period, and therefore the role of midwives. I keep saying the role of the midwives because ideally we expected to have normal health even before conception. But within our health system, I think the earliest opportunity we have to meet with people is during when they are pregnant. And therefore we can do something at that point in time to ensure that the children that are going to be born have a chance of having normal lung development and growth, and therefore reduce the risk of lung diseases. Now we move on to the common respiratory diseases. Just a bit of revision here. We know most of them in childhood, like pneumonia, tuberculosis, asthma, bronchiectasis, similar diseases in adults, although we add on chronic obstructive pulmonary disease and maybe lung cancer. So these are both infectious in origin, but we also have non-communicable diseases. Again, the risk of having any of these diseases increases among those people who were born with suboptimal lung function because of insults that happened during pregnancy, compared to those people whose mothers had a normal pregnancy. And I'll just go through the burden. And the common ones we probably already know about, and later illustrate the risk factors and how they lead to increased burden. So childhood pneumonia in Uganda, it's among the top 3 causes of childhood morbidity and mortality. And according to the research that has been done over the years, the mortality rates range between 10 to 30%. Of course, a lot of work has been done. We are having fewer pneumonia deaths, but they are still there. And for us in pediatrics, we're still uncomfortable with the rate of decline. And so we've moved from focusing on a few interventions and looking at the whole scope of interventions that could help prevent pneumonia deaths. And some of them are directly related to the risk factors that I'll describe later. I want to highlight more around childhood asthma. This is an illness that is common in children. In fact, it is the most common chronic disease in children, but it's still very much under-recognized, whether among the general population, but also under the clinicians. We've been able to do some work over the years, and we know that if you're looking at older children, 8 to 14 years, about 2 out of 10 would have asthma symptoms. But these symptoms are actually much more common in the young age group, the under 5s. Many of them present with recurrent symptoms of cough, difficulty in breathing, sometimes wheezing. But it's very much under-recognized, as you'll see later, that many of these are actually treated as pneumonia. So the burden of the non-communicable diseases in children is also as high as we see for the communicable diseases. I'll move briefly to adults. Again, I picked out chronic obstructive pulmonary disease, another common disease, but which is very much under-recognized. And I think until recently, it wasn't even appearing in the HMIS forms, so that there was no data that would be captured to indicate the burden, even in health facilities. But we've been able to do research, and we find that much as we have less COPD in urban centers, but it's a bigger problem in the rural setting. And if you compare the women and men, again, as opposed to what happens in high-income countries, we find that women, especially in the rural women, they have more COPD than men. And we think that it's probably not related to tobacco smoke, as most techniques will tell you. It's around what women do every day, and that is cooking. And so within the work we are doing in Busoga region, we are we are trying to see, is there any way we can actually reduce exposure of our mothers to this biomass smoke or smoke from cooking so that we can prevent them from getting COPD. We shall get some results later, but that is the origin, or that's what we are thinking is the cause of COPD being more common in the women as opposed to the men. So I'll briefly move on to the risk factors for these common respiratory diseases, and they are broadly categorized into four. It's either your genes or the environment you're living in. There is a lot of work done around nutrition and lung health, but as well as the diseases. If your mother has some chronic diseases, the risk of being born with suboptimal lung function increases. I'll pick out number 2 and number 3, not because the genes are not important or the health of your mother is not important, but I believe if you're going to have any interventions, probably the environment and nutrition, these are modifiable risk factors. And so we can discuss some of the things we can do to reduce the risk of lung diseases. So again, I'm going back to this graph. If you're looking at these risk factors, for example, the air pollution or the tobacco smoke, the question we have as researchers, at what point should I intervene and what should I intervene with? Again, I just wanted to emphasize that the intervention should ideally be before preconception, but because within our health system, we don't get to see most of the women before conception, or even when we see them, we are not thinking about their health and therefore the baby they will conceive and what will happen to their lungs. So our biggest chance is actually to have or take care of these women at the time when they come to us when they are pregnant. And so if you think about interventions, we could start thinking about the time of conception, through pregnancy, at the time of birth, how we have the birth being conducted and so forth. But we don't have to end there because the early childhood period is also very important. And without going into the details of these risk factors, you'll just notice that the 4 categories cut across the different stages. In the preconception, the genes, the nutrition, the environment become very important. The same thing happens during pregnancy, but even after you're born, your nutrition, the environment you're living in, and your genes you're born with eventually determine how your lungs function and therefore the risk of lung diseases. Many of us are familiar with this, and these are pictures just demonstrating how we, either as children or our mothers, some of them who could be pregnant, are exposed to high levels of air pollution. And this air pollution could be in our homes, especially for the women who are cooking. And because of the behaviors or the way we've been trained, the children are usually around their mothers. So you can imagine a mother who is cooking in a kitchen which is highly polluted, she's pregnant, she's taking in the fumes and they're reaching the placenta and affecting the growth of the lungs. And then the baby is born and is around the mother in the kitchen. Again, it's a highly polluted kitchen, so the insult is continuing. This child certainly has a very high risk of developing respiratory diseases compared to a child probably whose mother was using gas or electricity and was not exposed to these levels of high pollution. And so as we think about interventions around air pollution, we should be looking at the behavior around the women when they are pregnant, the behavior of the children, the exposure they have along their path of life, and be able to intervene effectively. Another common scenario, which we sometimes ignore, but I'm sure people in Ginger may be familiar with this, with some of these photographs. The first photograph, I think we took that photograph from around Kachira. Occasionally, we may have these high levels of air pollution arising from sugarcane burning for whatever reason, I don't know. But we know that even though it's very brief, as long as somebody is exposed to very high levels of pollution, it actually affects their lungs. And some of the commercial activities, they are good activities, they give us a source of income, we enjoy the food. But in the long run, they leave a lot of pollutants in the air. And then these ones affect the pregnant women and eventually the fetus. And by the time the babies are born, they have a high risk of getting respiratory diseases. Recently, we had a workshop with some members of the community from Ginger. And right now we are trying to increase the awareness about air pollution. Many times we are thinking about air pollution in our homes. So we are able to buy solar panels, we are able to buy improved cook stoves. But if you're in an urban setting and you're working in the city, there are other sources of air pollution which you should actually be aware of, which could be contributing to the risk of you getting respiratory diseases. So just to highlight, this is what we call the air quality index. And it just gives you an insight. If you have the equipment that measures it, it can tell you whether you're exposed to what would call reasonably low concentrations of particulate matter, which we call PM 2.5. It's one of the most dangerous particles in the air pollutants because it goes down right into the lungs and causes damage. So if you measure and you're in the green zone, meaning that it's less than 12.5, 12 concentration micrograms per meter cubed, you're okay, you're in the green zone. But then as it increases, you go into the moderate zone, what we call unhealthy for sensitive groups. For example, if somebody already has asthma or COPD, and they find themselves in air polluted to that level in the unhealthy zone, they experience difficulties. They may actually end up in the emergency with an exacerbation. When it gets to the red zone, it's unhealthy for everyone. The purple zone is very unhealthy. And when it's above 250, it's actually a hazard. And so I'm going to share what Ginger looks like because we are working with a group called AirCore, and they've been able to monitor the air pollutants within the different cities in the country. And so in the eastern region, that's what happens. So that's a recording for a single day from around midnight to almost midnight the following day. And so they've been able to bring out patterns, what happens at different time, explain what commercial activities are going on that could be responsible for the increase in the air pollutants. Although Ginger is not expressly shown in this graph, but if you compare, for example, Ginger and Bali, they may have some similarities. And so if you want to know where Ginger lies, maybe you could be looking at the graph from Bali, and that's the topmost graph. And it shows that at around 6, 7, 8 p.m., we actually have dangerous levels of air pollution. But also what is very important that apart from Kapchora, the rest of the cities, they are hardly ever in the green zone. And so the bottom line is that residents of Ginger City are actually exposed to high levels of air pollution throughout the 24 hours of the day. And if I was able to bring the graph for the week, it wouldn't be very different. And so as we are thinking about interventions, we can think about in the individual interventions or household interventions, but in the aspect of urban health, we need to think about interventions that is going to prepare quality around the places where we work. So what happens when either the pollutants from the air in the kitchens or in the places where you work or where we're moving from home to work, when we are exposed to those levels of high pollution, what happens? So I'll start with what happens to the unborn baby. So what happens that if a woman is pregnant and she inhales polluted air, it contains many particles, but we know carbon monoxide is one of them, and what I call particulate matter is one of them. And apart from damaging the woman's lungs, those particles actually find their way through the bloodstream and go up to the placenta. Within the placenta, they can cause inflammation, and therefore they affect the placenta blood flow. And any midwife here would know that once that happens, then the nutrition for the baby is affected. And if the baby is not feeding well or receiving enough nutrients, all the organs, including the lungs, the way they grow and develop will be affected. And so by the time they are born, they already have suboptimal functioning. But we know that some of the particles actually have the direct effect on the baby. Besides affecting the placenta, they go straight to the growing baby. And as a result, we have things like low birth weight or preterm births. We have women having bleeding during pregnancy. Like I mentioned, poor lung function at birth, which increases your risk of getting respiratory diseases. And so it's very important to look at this time of pregnancy or antenatal care and see how we can prevent most of these things. If you're born and you're exposed to those high levels of air pollution, it can affect your lungs, your heart, your brain, your eyes. And as you can see, you can end up with pneumonia when at least 50% of the childhood pneumonia cases are explainable by the high levels of air pollution in our environment. Asthma and asthma exacerbations, lung cancer, COPD, the heart attacks. For those of you who are beating your children because they are coming back with not distinctions but credits or passes, F9, it may be because they have poor neurocognitive functioning related to air pollution they're exposed to either during pregnancy or early childhood. It may not be that they are just playing around. So we know that air pollution is that bad. It can cause stroke and cataracts. And these are just few of the things that happen when somebody is exposed to air pollution. And so we think it's a very important risk factor to deal with here to reduce risk of diseases. Then I'll talk about maternal nutrition. Again, we think this is a modifiable risk factor. I know in our antenatal classes, tell our mothers to have a balanced diet, whatever that means to each one of us. But a lot of research has shown that maternal nutrition during pregnancy can affect actually your airway size, the alveoli, which are responsible for gaseous exchange. And so if your mother is not eating appropriately during pregnancy, this has been associated with poor birth outcomes, including low birth weight and prematurity. And unfortunately, again, the low birth weight babies and premature babies have been shown to have a higher risk of respiratory diseases. There have been some specific nutrients that have been studied, like maternal iron status during pregnancy, maternal vitamin A during pregnancy. Some studies have looked at vitamin D. But the bottom line is that these nutrients, once they're not sufficient during pregnancy, the lung growth and development of the fetus is not appropriate because they're necessary for the different processes that happen during the lung development. And so such babies end up being born with suboptimal lung function, and this increases their risk of getting pneumonia, tuberculosis, asthma, and other diseases in adulthood. We've done some work at the Lung Institute. There is a study which we call the Impala study. And in this study, we had a cohort of 564 pregnant women that we recruited at different gestational age. And we are basically asking ourselves, do these women have sufficient levels of serum vitamin D such that their babies can tap into this and be born with normal lung function? We're surprised that up to 67% of them actually have low vitamin D levels. We're able to follow up these mothers until the time of birth, and we measured the lung function of their babies at 6 weeks. We are still analyzing that data, but what we already seeing is that most of these babies are born with suboptimal lung function, and probably no wonder we are having a lot of respiratory diseases in our children and even in adults. These are women of Uganda in one rural community in Chamliwa. Probably they are not so much different from the women of Busoga. So you could be able to generalize some of the results for most of our settings and say that women do not have sufficient levels of vitamin D to support normal growth and development of their baby's lungs. Besides vitamin D, we looked at the food they eat. Again, looking at main food groups. fruit? Do they eat some eggs? Are they eat fish and vegetables? And the reason we went into the details of their diet, because we know that the nutrients that are supposed to support the abnormal growth of lungs and even other organs are derived from these diets. But key within these diets are fruits and vegetables. But we found out that majority of these women during pregnancy consume very little. If you look at the blue bars are the majority, or most, the majority across most of the foods, and the blue bars is where there was zero consumption of any of those foods in any given week. And so, again, if you just look at the dietary habits, they point to the fact that most of our women during pregnancy are not able to consume diets that would support the provision of sufficient nutrients for the growth and development of the lungs, but even other body organs of the fetus, and therefore have normal functioning by the time they are born. And so, having seen that picture in sub-Saharan Africa, in Asia and other areas, some interventions have been proposed, again focusing on the early life. So the questions, the early life is quite broad. Many times we're now speaking about the 1,000 days. So the questions we have, at what point, when should we intervene? How should we intervene? There have been some trials. In some cases, we know what works. Sometimes we don't know what is supposed to work. We may know what works, but how it works is also very challenging. So the reason I'm going to share this information is not that I have the answers, and I think I want to stimulate a discussion of thoughts, because I know on this forum there are researchers, there are clinicians, there are public specialists, people into programming. I think we can put our heads together, try and think through what we need to do differently, or what we need to do to ensure that we minimize or we modify those risk factors around nutrition, as well as the air pollution. And so I'll share the work we've done in Ginger. So in this work, we worked with the midwives in health facilities in Ginger district. And what we basically did was to educate them that biomass smoke, that is basically smoke that arises when we are cooking, is dangerous to a pregnant woman and the woman and the postnatal mother. And so they were able to share this very information during the antenatal classes. And later on, we went back to find out that when these mothers attended these antenatal classes and got this information, were they able to do anything about it? Is it something we could use because it's potentially cheap, it can be embedded within the health system, and it could help reduce the exposure to air pollutants which affect our children's lungs. So this is one of the midwives giving the women antenatal classes. Lucky enough, there were some children, so it reached quite a number of people. And they're using materials developed by our team, but approved by the Ministry of Health. And they are simple materials, as we see the photographs, the information there, and they used them very well. And this was evidenced by the results that we got. That when we went back to the women, it was 3 months later, and we asked about what we learned in the antenatal classes, we found out that many of them actually gained knowledge. Many of them didn't know that the smoke, when they're exposed to it, it affects their unborn babies. They only knew that it makes your eyes water and you cough a bit, and that's the end of the story. So we're able to find out that there were actually improvements in the knowledge about the risks of biomass smoke. Some of them actually made some changes within their means, like keeping away from smoke. Contrary to what we are doing, when you start cooking, you have to sit by the cook stove till the food is ready. Some of them started moving away so that they could reduce the exposure. Some of them had intent to change, like making plain cook stoves, buying solar panels, putting chimneys on their houses so that they could turn away the smoke. But we found that there was a major barrier to poverty. But these results indicate that I think if we intensify these efforts, we should be able to save some lives. course, there will be reduction of exposure to biomass smoke. In other countries, they have been able to do some trials. For example, this is a trial that was done in the Guatemala highlands, and they wanted to find out if women are given clean cook stoves, meaning that they emit less pollutants, it can help reduce the risk of pneumonia among the children. Unfortunately, it wasn't very successful in reducing the incidence of pneumonia, except for those who were diagnosed with severe pneumonia. The same thing happened in Malawi. Again, they tried to give people improved cook stoves, but they did not see a significant difference between those who had received the improved cook stove as opposed to those who had the traditional stove. So again, the question as when to intervene becomes very important. But it's not all bad news. This study was done in the US, and it was about the air pollution, what we call ambient air pollution in the cities. So what they did, they measured the lung function of the children who were around a particular location, but we know it was around industries and very busy roads. And then they did interventions to reduce the amount of pollutants produced by industries. They closed some of them, they educated people on how to avoid polluted areas and so forth. And what they saw along the way, this is a very busy graph, but it just shows that over the years, between 1995 and 2010, when they were monitoring the lung function of the children in that area, they noted that as they reduced the nitrogen dioxide, which is one of the pollutants, the lung function measured by forced X-ray volume was increasing. The same happened when they measured the particulate matter 2.5. As it reduced, the lung function improved. So this gives us hope that once we do things right, we are actually able to.
Dr. Rebecca, we have 4 minutes for the presentation, just to remind you.
Okay, so lastly, I think my clock was a little different. So lastly, this is about the dietary interventions. And I think the only thing I need to mention here, what we shouldn't be trying is whether to do supplements, maybe vitamin D, vitamin A, have been very unsuccessful. We have to use approaches of the diet. So I think the component of health education and what they need to include in their food becomes very important. The other interventions that I will not mention, which we're already practicing, but I just wanted to say that as we move into the coming presentations, the role of early screening and management is very important as a secondary prevention mechanisms for the lung diseases. And so this is the work that has been done again in Ginger, related to what I've just mentioned. We still have challenges in ensuring that we assess our children sufficiently and therefore treat them optimally as a way of preventing complications of lung disease and therefore the risk of chronic lung diseases. So I think I'll just go to the key messages for today, is that early life, or what I call prenatal events, affect lung growth and development and therefore lung function. And we know that suboptimal lung function at birth is a risk factor for respiratory diseases throughout the life course. And therefore, if we are to look at prevention of lung diseases, we should be thinking about the life course approach. I think that's when we can be successful. And just to say that environment and nutrition are modifiable risk factors. And I think if we address them, we should be able to make some headway in prevention of lung diseases in our population. I just want to acknowledge all those teams of people. And I thank you again for this opportunity. Happy to take some questions or comments if they come through. Thank you, Chair. Back to you.